I've got to say that the advent of thermoplastic fills has increased my success rate. That would surely be expected given the superior ability these systems have to fill canals three-dimensionally.
First of all, I doubt you can refer me to a single study that shows higher success rates using thermoplastic techniques. Secondly, how do you deal with the fact that everything heated up beyond body temperature must cool to body temperature and shrink in the process? Shrinkage is not compatible with three-dimensional sealing of the root canal system.
Come on. There's no comparison to the fills we got when we were doing room temperature single point or lateral and vertical condensation. By thermoplasticizing the gutta percha, we molded to the most intimate details within the canal system. By applying pressure for 10 seconds or so after placement of the thermoplasticized gutta percha, we compensate for any shrinkage that might take place.
It's not might take place. It will take place, and the application of 10 seconds of pressure after obturation does not account for the shrinkage and cooling process that research states goes on from anywhere from 45 minutes to 10 hours. Even if the shrinkage process went on for 5 minutes, I don't know of a technique where someone is going to place pressure for 300 seconds. And remember, if you are backfilling with an Obtura-like glue gun, you can't place a column of several millimeters of molten gutta percha, apply pressure at the top of the heap, and expect that to have some compensating effect on the gutta percha 2 or more millimeters away from the compaction? No. You'd have to apply a millimeter of thickness of gutta percha, apply at least 300 seconds of pressure, add another millimeter, and another, again add pressure, and so forth. No one is going to do that.
You say we don't get a three-dimensional seal. Then how do you explain the additional puffs of cement we get when using this technique? We couldn't possibly get these lateral canals without a system that provided a combination of pressure and a molten semi-liquid material.
For some reason, you are making a connection between the presence of lateral canals as proof that a three-dimensional fill has occurred. This is not necessarily the case. You may have pushed cement through canals that lead to defects along the length of the PDL, but that doesn't mean the material has not shrunk as it cooled. And that would be after the cement or gutta percha has extruded into the PDL.
Okay, I'll concede that it is possible that shrinkage does occur to some very small extent, but I would say that this technique is far superior to trying to get a uniform seal with room temperature gutta percha. Not only does the placement of room temperature gutta percha points produce voids, but lateral condensation sets up stresses in the gutta percha that rebound when those stresses are removed. This leads to voids. I would also mention that lateral condensation can easily lead to excessive stresses within the root that can lead to fractures, sometimes undetectable until sometime later.
Don't say shrinkage occurs only to a small extent. The literature has determined that thermoplasticized gutta percha can shrink as much as 5%. That is significant because other studies have pointed out that shrinkage of no more than 1% can lead to leakage along the root or the fill interface. Furthermore, when talking about room temperature fills, you are emphasizing gutta percha's role and minimizing the impact of the cement. In the world of thermoplasticized gutta percha, it is the gutta percha that is king, with the cement playing a supporting but minor role. One view of the room temperature obturation world is to depend primarily on the cement to create that seal. Now, you can only do that if a couple of things happen. The cement must be highly resistant to water degradation. This is solved by using a polymer, like epoxy resin cement, that is highly resistant to dissolution. Sure, if you continue to use particulate cements like ZOE and calcium hydroxide cements in thick layers, that has the potential to dissolve rapidly, leaving a void and avenue for leakage. Once you have a cement that is highly resistant to leakage, you need a system that allows you to apply the cement without driving excess over the apex. Because this was never achievable, dependence on the more easily controlled gutta percha remained in fashion. With the bidirectional spiral, however, we can thoroughly coat the walls of the canal without fear of driving excess cement over the apex.
Man, you sure are saying a lot, but at the end of the day, you have a system that is dependent upon a single point with the rest of the fill being dependent upon the cement interface. That is like a single point sitting in a sea of cement. How do you expect to get an adequate fill that way?
You're missing the point here. There is nothing inferior about an epoxy resin cement compared to gutta percha. They work together. The ability to flood the canal with this cement while preventing any gross extrusion beyond the apex allows the dentist to place a much greater portion of the burden on the fill on the shoulders of the cement. Think of the gutta percha point as nothing more than a carrier. and a driver of the cement. After the canal has been flooded with cement, the point itself is liberally coated with cement. The gutta-percha point drives the cement laterally with the excess escaping coronally. Minimal cement is driven apically because the driving force is a wedge, not a piston. In fact, the amount of force applied to the apically placed cement is so small that it doesn't have enough force behind it to violate an intact PDL. As for a single point sitting in a sea of cement, the point fits to the canal space at least 85%, if not 95%, in the apical third. That is hardly a single point sitting in a sea of cement.
With all that cement, you're going to get shrinkage as the material polymerizes. That puts you in no better shape than that occurring from the shrinkage you complain about with thermoplastic systems.
While polymeric shrinkage is a problem with methacrylate cements, it is not an issue with epoxies. They undergo no shrinkage during polymerization. They also have some other additional useful properties that methacrylate cements don't. They bond to everything, and I mean everything. They bond to the calcium in the dentin and the zinc in the gutta-percha. Perhaps the key to their effective usage is the fact that they are placed into the canal at room temperature and then warmed to body temperature, expanding about 1.75% in the process, during a time when it is still flowable, thus avoiding any expansive stresses. They have shown to be equally effective as a seal, whether they are in a thick or a thin layer.
I simply cannot believe that a whole method of obturation, including expensive paraphernalia like thermoplastic compactors and glue guns, are not doing a better job. These techniques are supported by some of the top clinicians in the country who have written articles and given lectures on their benefits. Are you saying they're all wrong?
What I am saying is listen to the facts, not to the people. Well-established facts do not have an agenda, but people usually do. And it may not be the same agenda that you have. If thermoplastic obturation is as great as the advocates say it is, it should withstand the challenges I've made to it. However, if at the end of a fruitful discussion you now have doubts, that's a good thing. You are replacing unsupported faith with an analytic approach that should steer you well.
One last thing. If epoxy resin is so good, why even use a gutta-percha point?
It's so good that you would have a hard time removing it if it were the only material in the canal. The gutta-percha gives you a path to the apex in the event that you want to remove it. Gaining depth without a gutta-percha point being present would be a challenge. With it, gaining depth is routine, and widening is strictly a matter of using wider instruments. While the epoxy is much stronger than gutta-percha once it polymerizes, it is still significantly softer than dentin. This makes retreatment of the creation of a post hole a fairly simple task if required. Of course, a root canal done poorly in the first place presents its own challenges when it comes to retreatment, but that's not what we're talking about here.
I have to give what you have said some more thought, but at first blush, it seems to make sense. I wonder just what those supporting thermoplastic obturation will say when I repeat the questions and answers you have given me here today. Funny, I thought I'd have you on the defensive in this dialogue, but you turned the tables on me.
It wasn't I who turned the tables on you. It is simply the reality of the situation that with a bit of explanation lets you see the whole picture more clearly.